Welcome back to the Deep Dive. Our mission, as always, is to cut through the noise and really equip you with a mastery-level understanding of complex topics, like the pros.
That's the goal.
Today, we are plunging into Chapter 279 of our source material. It's a really comprehensive look at deep venous thrombosis DVT and its dangerous partner, pulmonary thromboembolism, or PE. We're going to cover, well, everything. From the epidemiology, which can be quite silent, to the really nuanced treatments. We want you to walk away with every essential nugget of knowledge.
And it's important to note this deep dive isn't just about DVT and PE. The source material actually kicks off with some critical insights into renal and hypertensive disorders first.
Right, the kidneys and blood pressure.
Exactly. It's a powerful reminder of how interwoven our bodily systems are.
Right.
And we'll see pretty quickly why understanding that context really enhances our grasp of cardiovascular health overall.
Okay.
So yeah, prepare for an intense, comprehensive exploration. The aim is for you to be truly well-informed by the end.
And I have to say, I found some truly surprising, almost alarming facts in here that we need to unpack.
Oh.
Like, did you know that in the U.S., PE-related mortality death rates have actually been increasing among young and middle-aged adults since 2007?
That's concerning.
And the COVID-19 pandemic. It revealed just widespread, often life-threatening thrombotic effects, even in patients getting standard preventative care.
A huge issue during the pandemic. Huge.
So our goal today is to extract every crucial detail from this chapter, connect all the dots, so you can understand this topic like a true expert. All right, so before we fully immerse ourselves in DVT and PE, let's set some of that crucial context you mentioned. Our source material starts by touching on severe hypertension and related kidney issues. It's a vital reminder, like you said, of the systemic nature of cardiovascular health. Understanding this connection feels key before we dive into the main event, Chapter 279.
Absolutely.
So regarding malignant hypertension, what's maybe the most important takeaway for us there?
Well, malignant hypertension is, a very severe form of high blood pressure. It comes on rapidly, often causes organ damage. But what's compelling, maybe a bit counterintuitive, is that its prevalence has actually been decreasing in Western countries.
Oh, really? Why is that?
It's largely thanks to better access to medical care, better adherence to treatment, and just more effective antihypertensive drugs being available.
Okay.
But unfortunately, it does persist in regions where that kind of medical support isn't as readily available.
So it's really a tale of two worlds, in effect.
You could say that, yeah.
And for those in Western countries who do experience it, what are the common triggers? What brings it on?
Often it develops in patients who, they've been prescribed medication for hypertension, but maybe they neglect to take it consistently. Adherence is key.
Right.
We also see it precipitated by the use of vasospastic drugs. So drugs that constrict blood vessels. Cocaine is a particularly notable example there.
So patient adherence and also substance use.
Exactly. It highlights both those factors.
Now, when malignant hypertension hits, the kidneys are often right on the front lines, aren't they? They can experience significant damage. What are the telltale signs of that renal involvement?
Typically, we see a rising serum creatinine. That's a blood test marker indicating declining kidney function.
Okay.
There can also be hematuria, that's blood in the urine, and proteinuria, which is excess protein in the urine. Both signal kidney injury.
And what about the deeper biochemical picture? What else does the body reveal when it's under that kind of extreme stress?
Well, biochemically, we often find evidence of hemolysis. That means red blood cell destruction.
Yep.
So you see anemia, you might see schistocytes on a blood smear. Those are fragmented red cells that indicate damage to small blood vessels and an increase in reticulocytes, which are immature red cells the body pushes out trying to compensate.
Wow.
Yeah, those findings, alongside other markers of kidney failure, they paint a pretty grim picture of systemic distress.
Now, here's a really significant point about disparities. Our source highlights that African-American males in the U.S. are more likely to develop rapidly progressive hypertension and kidney failure. Why this particular vulnerability?
That's a critical question. And the source points towards the role of specific genetic polymorphisms, variations in a gene called APOL1.
APOL1, okay.
These APOL1 genetic variations are particularly common in the African-American population. And what's really significant is that they predispose individuals to a specific type of kidney damage called focal sclerosing glomerular disease.
Right.
And in those cases, severe hypertension can often develop at younger ages, frequently as a secondary consequence of the underlying kidney disease itself.
I see.
It's a powerful example of that complex interplay between genetics, ethnicity, and kidney health.
So it's not just lifestyle or access to care, those matter, but there can be a deep-seated genetic predisposition at play for some individuals. That's a crucial distinction.
It really is.
Okay, shifting slightly now, let's talk about a term that's been around in the medical world for a long time: hypertensive nephrosclerosis.
Hmm.
Historically, there was this widespread belief that even, moderate, less severe degrees of hypertension would eventually lead to changes in kidney blood vessels and, over time, a loss of kidney function. Sort of a direct cause and effect assumption based on associations.
Right, that was the thinking. And as a direct consequence of that long-held assumption, a substantial number of patients who eventually progress to end-stage renal disease, ESRD, without any other clear, specific cause identified. Well, they often get labeled with hypertensive nephrosclerosis.
So it became kind of a default diagnosis.
Essentially, yes. When other specific causes weren't apparent, that was often the designation assigned.
And when we look at kidney tissue under a microscope in these cases, what typical changes do pathologists actually find?
Well, common findings include afferent arteriolar thickening, meaning the small arteries leading into the kidney's filtering units get thicker. There's also deposition of this homogeneous eosinophilic material, often called hyaline arteriosclerosis. It's sort of a glassy, pinkish substance that builds up in the vessel walls.
Right.
And both of these changes lead to a narrowing of the vascular lumina, the inner channel of the blood vessels, which impedes blood flow.
And clinically, how do these patients often present? What other signs might point towards this condition besides the high BP?
Well, beyond the elevated blood pressure itself, they frequently show retinal vessel changes. Things like arteriolar narrowing or what we call arteriovenous crossing changes. You can see those during an eye exam. They also often develop left ventricular hypertrophy, where the main pumping chamber of the heart thickens because of that increased workload pumping against high pressure.
Now, what's fascinating here, and maybe a bit counterintuitive as you said before, is that despite these clear pathological and clinical signs, the precise role these vascular changes play in causing kidney function decline isn't entirely clear-cut.
This is a really crucial point.
Our source highlights that postmortem and biopsy samples from normotensive kidney donors, people with normal blood pressure, can actually show similar vessel changes. What does this paradox suggest?
It suggests that hypertension isn't the sole culprit, or maybe even the primary driver, in all cases of these specific kidney changes. These findings, these vascular changes, are often associated with aging, with dyslipidemia, unhealthy fat levels in the blood, and with glucose intolerance. So while hypertension certainly aggravates kidney disease, no question, these vascular changes might be a more generalized phenomenon influenced by multiple factors, not just blood pressure alone.
And how does this understanding impact treatment? Does simply lowering blood pressure fix the kidney dysfunction specifically identified as hypertensive nephrosclerosis?
Well, this is where it gets complicated and raises important questions about how effective our current classifications really are. While lowering blood pressure is vital, absolutely vital, and it does slow the progression of proteinuric kidney diseases, and it definitely reduces the significant cardiovascular risks tied to chronic kidney disease. Antihypertensive therapy does not seem to specifically alter the course of kidney dysfunction that has been identified solely as hypertensive nephrosclerosis.
Interesting.
Yeah, it makes us reconsider whether that label truly pinpoints the direct cause of kidney decline in every single case. It really emphasizes the need for a more nuanced understanding.
Okay, so to sum up this initial contextual piece, we've seen how severe hypertension can directly damage kidneys, sometimes driven by specific genetic factors like APOL1,
Right.
and how conditions like hypertensive nephrosclerosis are perhaps more complex, maybe not solely caused by BP than previously thought.
Exactly.
This interconnectedness is a powerful reminder that the body systems don't operate in isolation. Right. So with that crucial foundation laid, let's now zoom out and look at the big picture of venous thromboembolism, or VTE. This is our core deep dive into Chapter 279.
This is the main event.
Exactly. And it's where we truly begin to unravel the profound medical and also economic impact of DVT and PE.
And VTE, as you mentioned, is that broad term. It covers deep venous thrombosis, the clot in a deep vein, usually the leg, and pulmonary embolism, which happens when a piece of that clot breaks off, travels and lodges in the lungs.
Yeah.
And these conditions, they're far more than just acute medical events. They're significant causes of cardiovascular death, chronic disability, and frankly, immense emotional distress for patients and their families.
The statistics from the U.S. are quite stark, aren't they? It's estimated something like 100,000 to 180,000 deaths annually are attributed to pulmonary embolism in the U.S. alone.
It's a huge number.
And what's particularly alarming is how this fits into that broader picture you mentioned earlier, the changing life expectancy in the U.S.
Indeed. The United States has seen this really alarming trend since about 2015, a decrease in overall life expectancy. And this isn't just a minor blip, it's a significant shift, primarily driven by an increase in deaths among young and middle-aged adults across all racial groups.
And while, a lot of the public discussion focuses on things like drug overdoses, alcoholic liver disease.
Right, the opioid crisis, for example.
Exactly. But what other, perhaps often overlooked health issues are playing a significant role in this decline?
Well, it's critical to recognize that increasing deaths from heart and lung diseases, along with hypertension, stroke, and diabetes mellitus, these are also significant factors contributing to this really unwelcome trajectory in U.S. life expectancy. These chronic conditions are really compounding the problem.
And specifically concerning PE, the age-standardized mortality rate, death rate adjusted for age, has been increasing among young and middle-aged adults in the U.S. since 2007.
Increasing, yeah.
Even among the elderly, where it was decreasing, that rate of decrease has slowed down. What does this tell us about PE management and prevention in the U.S. right now?
It's deeply concerning. This trend suggests that despite medical advancements, we're either failing to prevent PE effectively in these younger groups, or perhaps we're not diagnosing and treating it rapidly enough. And adding to this complexity, there's a clear socioeconomic disparity. PE patients living in lower socioeconomic status zip codes experience increased in-hospital mortality.
Wow.
That definitely hints at broader systemic issues impacting access to timely, quality care.
And this picture becomes even more striking when we compare the U.S. to other developed nations. Canada and Denmark, for example, have seen their annual age-standardized mortality rates for PE decrease across all age groups.
Decrease. Right.
And Europe as a whole has also seen a linear decrease since 2000. What's the biggest implication, do you think, of this stark contrast?
Well, if we connect this to the bigger picture, that contrast is really telling. It strongly implies significant differences in healthcare systems, maybe public health prevention strategies, or just overall population health approaches between the U.S. and these other nations.
Right.
It raises critical questions. How are these countries succeeding, where the U.S. seems to be struggling? Are they better at early detection, prevention campaigns, integrating care for chronic diseases that contribute to VTE risk?
Yeah.
It really suggests an urgent need for the U.S. to examine what other developed nations might be doing differently and perhaps better in terms of VTE prevention and management.
Then, of course, the COVID-19 pandemic hit in 2020, and that revealed an alarming new dimension to this whole VTE landscape. Initially, the focus was understandably on the lungs, the respiratory syndrome.
The breathing, yeah. But what quickly became apparent was the widespread thrombosis this viral illness caused, just massive clotting issues.
Yeah.
Patients developed extensive DVT and PE, often even while receiving standard preventative blood thinners, we call pharmacologic prophylaxis, during their hospital stay.
Even with prevention. Wow.
Even with standard prevention. And autopsy findings were particularly revealing. About 1/4 of these patients showed both macrovascular large vessel and microvascular tiny vessel PE. It indicated a pervasive thrombotic process throughout the lungs.
And it wasn't just venous clots either, was it? Arterial thrombosis also occurred.
That's right, leading to serious events like heart attacks, myocardial infarction, and strokes in COVID-19 patients.
So what was driving this multifaceted attack on the body's clotting system?
Well, as detailed in Figure 279-2 in our source, the contributors formed a really complex interplay. You had excessive inflammation, often called a cytokine storm.
Right, heard that term a lot.
Significant platelet activation. Endothelial dysfunction, basically damage to the inner lining of blood vessels. And stasis, sluggish blood flow, often from being immobilized. This combined assault on the body's delicate hemostatic balance was absolutely critical in driving those widespread thrombotic events we saw.
And even for those who survive an acute PE, the challenges often don't end when they leave the hospital, do they? What are some of the significant post-discharge challenges and long-term consequences patients face?
Well, one clear indicator is the high readmission rate, something like 14% within just 30 days for Medicare fee-for-service beneficiaries who had an acute PE.
14% in 30 days. That's high.
It's very high. And while the precise reasons are probably multifaceted, this rate strongly suggests we need to significantly improve that transition of care from inpatient to outpatient settings, ensuring patients are really well supported after discharge.
And beyond just readmissions, what about long-term quality of life? It sounds like there can be persistent issues even after the acute event is managed.
Absolutely. About half of all PE patients report persistent dyspnea, that's shortness of breath, chronic fatigue, and reduced exercise capacity.
Half is a lot.
It is. Furthermore, about a quarter still show persistent right ventricular dysfunction on an echocardiogram, even after their PE. This whole cluster of ongoing symptoms and cardiac issues is increasingly being recognized as post-PE syndrome.
And for some, these lingering issues can actually progress to an even more severe condition.
Yes, a subset of these patients may go on to develop chronic thromboembolic pulmonary hypertension, or CTEPH. It's a severe long-term complication where old clots basically scar the pulmonary arteries. This leads to chronic breathlessness, especially with exertion, and a significantly diminished quality of life.
So it's not just the lungs that are affected long-term. What
Well,
about damage to the veins in the legs themselves?
right, damage to the venous valves in the leg can lead to what's called post-thrombotic syndrome, also known as chronic venous insufficiency.
Okay.
This causes persistent ankle and calf swelling, leg aching, particularly after standing for a long time. And in its most severe form, as you can see in figure 279-3 from our source, it can even lead to deep skin ulceration, a really chronic and debilitating condition that severely impacts quality of life.
So what does all this mean for you if you're recovering from PE or maybe helping someone who is?
Well, it really emphasizes that the focus has fundamentally shifted. It's not just about surviving the acute event anymore. It's about ensuring a good quality of life and long-term well-being after a PE. It's about recognizing these potential ongoing challenges, the fatigue, the breathlessness, the leg issues, and advocating for comprehensive, continuous care to address them effectively.
Okay, let's peel back the layers now and really get into how DVT and PE develop. This is where we dive into the core pathophysiology, unraveling the intricate mechanisms.
Right, and at the very heart of thrombus formation, inflammation really takes center stage, a critical trigger for both acute PE and DVT. Our sources highlight this significant and growing link between various inflammation-related risk factors and medical illnesses that we now recognize as precipitants of VTE.
And Table 279-1 in the source gives a pretty compelling and quite broad list of these inflammation-linked conditions. It's not just the classic inflammatory diseases, is it?
That's correct. I mean, yes, you have chronic inflammatory conditions like ulcerative colitis, Crohn's disease, rheumatoid arthritis, psoriasis, but the list really extends to widespread metabolic conditions too,
Like what?
like type 2 diabetes, obesity and metabolic syndrome, hypercholesterolemia, especially high LDL cholesterol and lipoprotein, even acute illnesses like pneumonia, acute coronary syndrome, heart attack, acute stroke, sepsis, or septic shock. They're all on the list.
Wow.
Yeah, and then add cancer, cigarette smoking, even some medical treatments like erythropoiesis-stimulating agents or blood transfusions can contribute. It's a remarkably broad array, showing just how systemic inflammation impacts clotting risk.
Okay, so this raises an important question then. How exactly does chronic or even acute inflammation contribute to this prothrombotic state, this clot-forming state? What's the mechanism?
Well, it's thought that the inflammatory mediators, the chemicals involved in inflammation, can directly activate endothelial cells. Those are the cells lining the inside of our blood vessels. When activated, these cells become procoagulant, meaning they promote clotting. Inflammation can also activate platelets, which are crucial for clotting, and stimulate the release of tissue factor, a key initiator of the coagulation cascade.
I see.
So the implication for managing these underlying inflammatory conditions is profound. By effectively treating or controlling the inflammation, we might also be mitigating a significant risk factor for VTE. It really highlights the interconnectedness of systemic health.
Now, beyond inflammation, there are also specific prothrombotic states, often rooted in hypercoagulability, that increase tendency for blood to clot. Our sources point out two of the most common genetic mutations. Can you explain those?
Certainly. The first one is factor V Leiden. This is an inherited condition, typically autosomal dominant, meaning you only need one copy of the mutated gene.
Okay.
It causes resistance to activated protein C. Activated protein C is an important natural anticoagulant that normally inactivates clotting factors V and 8. With resistance, these clotting factors stay active longer, increasing the risk of clot formation.
Makes sense. And the second one?
The second is the prothrombin gene mutation, also autosomal dominant. This mutation leads to an increased concentration of prothrombin in the plasma. Prothrombin is a precursor to thrombin, which is a central enzyme in the clotting process. So higher levels mean a greater propensity for clot formation.
Got it.
It's also worth mentioning deficiencies in natural inhibitors like antithrombin, protein C, and protein S, while strongly associated with VTE, are actually quite rare in the general population. Factor V Leiden and the prothrombin mutation are much more common inherited risk factors.
Then there's acquired thrombophilia, meaning it's not genetic, it develops over time. What's the prime example there?
The antiphospholipid antibody syndrome is a key example. This is a condition where the body produces antibodies that attack certain proteins in the blood, and it predisposes individuals to both venous and arterial thrombosis. Now, here's a crucial nuance regarding recurrence risk. Counterintuitively, these common genetic mutations, like heterozygous factor V Leiden and the prothrombin G mutation, they don't actually appear to significantly increase the risk of recurrent VTE once the initial event has been treated and anticoagulation is stopped.
Oh, interesting.
Yeah. However, patients with antiphospholipid antibody syndrome are different. They often warrant indefinite duration anticoagulation, even if their initial VTE was provoked by something like trauma or surgery, because their risk of recurrence remains persistently high.
That's a really important distinction for long-term management. Okay, shifting away from genetics and specific syndromes, let's talk about the more common clinical risk factors for DVT and PE that go beyond just inflammation. These are the elements in everyday life and common medical conditions that bump up the risk.
Exactly. Our sources list common comorbidities like cancer, obesity, cigarette smoking, systemic arterial hypertension, chronic obstructive pulmonary disease, COPD, and chronic kidney disease. These are often intertwined conditions that collectively elevate VTE risk.
And it's not just internal body conditions, is it? Lifestyle and environmental factors play a huge role too.
Absolutely. Things like long-haul air travel, sitting for long periods, exposure to air pollution, surprisingly, and an increasingly prevalent sedentary lifestyle in general.
Yeah.
Hormonal factors are also at play. Use of estrogen-containing contraceptives, pregnancy itself, postmenopausal hormone replacement therapy, and of course, medical interventions like surgery and trauma are well-known precipitants.
That Japanese study you mentioned earlier about television watching really drives home the point about sedentary behavior, doesn't it? Can you remind us of that startling finding?
It's a powerful example. That study found that for every 2-hour per day increment of television watching, there was a 40% increased likelihood of fatal PE.
40% for every 2 hours. Wow.
Yeah. It vividly highlights how daily habits, seemingly innocuous, can significantly contribute to the risk of life-threatening thrombotic events. Really underscores the importance of physical activity.
Now, at the very foundation of VTE pathophysiology is something called Virchow's triad. This describes the 3 core elements that contribute to thrombus formation. What are they?
Right. Virchow's triad, it consists of 1, venous stasis, which is sluggish or slow blood flow. 2, hypercoagulability, that increased tendency for blood to clot we just discussed. And 3, endothelial injury, or damage to the inner lining of the blood vessels.
Stasis, hypercoagulability, endothelial injury.
Those are the 3 legs of the stool, so to speak. They don't necessarily all have to be present at the exact same time to trigger a clot, but their presence, especially in combination, dramatically increases the risk.
And how do these 3 factors ultimately lead to a clot forming? What's the sort of molecular cascade that happens?
Well, they work together, leading to the recruitment of activated platelets. These platelets then release microparticles, small vesicles containing pro-inflammatory mediators. These mediators, in turn, bind to neutrophils, a type of white blood cell, and stimulate them to release their nuclear material, forming these web-like extracellular networks called neutrophil extracellular traps, or nets.
Nets. Okay, so these nets aren't just passive structures then. They actively contribute to clot formation.
Precisely. Our sources explain that these nets, these prothrombotic networks, contain histones proteins that normally help package DNA. These histones actively stimulate platelet aggregation and promote platelet-dependent thrombin generation.
So they really ramp up the clotting process locally.
Exactly. They essentially create a localized environment that's perfect for clot growth. And this environment is typically characterized by that stasis, low oxygen tension, and heightened inflammatory responses, all very conducive to thrombus formation and stabilization.
Now here's a truly interesting and broad connection. The interaction between venous thromboembolism, VTE, and atherothrombosis, like heart attacks and strokes.
Yes, this is fascinating.
Our source highlights a surprising link. The presence of carotid artery plaque, which is a sign of atherosclerosis, actually doubles the risk of VTE. What's the significance of that discovery?
That observation was really pivotal. It led to the understanding of a broad bidirectional interaction among VTE, acute coronary syndrome, ACS or heart attack, and acute stroke.
Bidirectional, meaning it goes both ways.
Exactly. These three conditions, which might seem quite distinct at first glance, actually share remarkably similar risk factors and underlying pathophysiology. They're all driven by common elements: inflammation, hypercoagulability, and endothelial injury.
And how does this bidirectional risk manifest for patients? If you have one, you're more likely to get the other.
Precisely. Patients who suffer VTE are more than twice as likely to have a future myocardial infarction or stroke. And conversely, patients who have had a heart attack or stroke are more than twice as likely to suffer a future VTE. Yeah, this broad interaction has profound implications for holistic patient care and prevention strategies. It emphasizes that these aren't isolated events, but rather different manifestations of shared systemic vulnerabilities. It really suggests a need for more integrated screening and management across these conditions.
Okay, so once a deep venous thrombus forms, the next critical step in understanding PE is the embolization process itself. What exactly happens? How does the clot get to the lungs?
Well, these deep venous thrombies, which you can even see illustrated in Figure 279-5 in our source, they aren't always stable. They can detach from their original site of formation, typically in the legs or pelvis.
Right.
Once detached, these fragments emboli travel through the venous system, up the vena cava, into the right atrium, then the right ventricle, and finally get pumped into the pulmonary arterial circulation where they lodge, causing acute pulmonary embolism.
And there's a rare but really intriguing phenomenon called paradoxical embolism. How does that work?
Right. Occasionally, these thrombi can actually bypass the pulmonary circulation entirely and embolize directly to the arterial circulation. This can potentially cause a stroke or block an artery elsewhere in the body.
How does it bypass the lungs?
It happens if there's a structural defect in the heart, like a patent foramen oval, PFO, a small hole between the atria or an atrial septal defect. This allows the clot to cross from the right side of the heart directly to the left side and then out into the body.
Okay, that makes sense. No, a significant diagnostic challenge for PE is that many patients actually don't show any evidence of DVT in their legs when they present with a PE. Why is that?
It's usually because the clot, or at least the major part of it, has already detached and embolized to the lungs. It leaves no significant residual thrombus in the deep veins of the legs to be detected by examination or imaging like ultrasound.
Ah, okay.
This is why a negative leg ultrasound absolutely does not rule out a pulmonary embolism. The culprit may have already moved on.
So after a PE occurs, the body's normal physiology for gas exchange gets significantly disrupted. What are the most common gas exchange abnormalities we see?
Well, the most common are arterial hypoxemia. That's a decrease in the oxygen content of arterial blood, and an increased alveolar arterial O2 tension gradient, often called the A gradient.
The A gradient, what does that represent?
That gradient represents the inefficiency of oxygen transfer across the lungs. It indicates that something is preventing oxygen from moving effectively from the alveoli, the air sacs, into the blood. Think of it like a broken filter. The air is getting in, the blood is flowing past, but the oxygen just isn't making the jump into the bloodstream as efficiently as it should.
And what's happening at a more detailed level within the lungs to cause this inefficiency?
From a mechanistic standpoint, you get an increase in anatomical dead space. This means inhaled gas doesn't effectively enter the functional gas exchange units of the lung because of the blockage. Simultaneously, physiological dead space also increases. This happens because the ventilation, the airflow to some gas exchange units, exceeds the venous blood flow through the pulmonary capillaries in those areas. So that ventilation becomes inefficient. It's wasted ventilation, essentially.
So you're breathing, but the oxygen isn't getting to where it needs to go effectively.
Precisely.
Now, beyond these fundamental gas exchange issues, what are some of the other critical pathophysiologic abnormalities that arise following a PE?
Okay, several things happen. Firstly, you see an increase in pulmonary vascular resistance. This is primarily due to the physical obstruction of the pulmonary vessels by the embolus itself.
Right, the blockage.
But it's compounded because activated platelets release vasoconstricting neurohumoral agents like serotonin. These chemicals constrict blood vessels further.
Okay.
And these vasoactive mediators can cause ventilation-perfusion mismatching even at sites remote from the actual embolus. This helps explain why sometimes a relatively small PE can cause a disproportionately large AA oxygen gradient, a clinical finding that can otherwise be quite puzzling.
Interesting. So the impaired gas exchange is multifaceted then.
Absolutely. It stems from that increased alveolar dead space due to the vascular obstruction. Hypoxemia can also occur from alveolar hypoventilation relative to perfusion in the non-obstructed parts of the lung, or from right to left shunting of blood where blood bypasses the lungs entirely, or from an impaired carbon monoxide transfer, which indicates a loss of the functional gas exchange surface area.
And what about the patient's breathing pattern itself? Does that change?
Yes. Thirdly, there's often alveolar hyperventilation. This is a compensatory mechanism triggered by reflex stimulation of irritant receptors within the lungs. The body tries to increase breathing rate and depth to improve oxygenation, which often leads to that sensation of breathlessness.
And what happens to the airways themselves?
Fourth, patients can experience increased airway resistance. This is attributed to constriction of the airways located distal to the bronchi, which can further impede airflow and contribute to respiratory distress.
And finally, what about the overall stiffness or compliance of the lungs?
And finally, yes, there's often a decreased pulmonary compliance. The lungs become stiffer, harder to inflate. This can be caused by lung edema fluid accumulating in the lung tissue, lung hemorrhage, or a loss of surfactant, which is the substance that helps keep the alveoli open and compliant. All of these contribute to the overall respiratory compromise seen in PE.
Perhaps one of the most critical aspects of PE pathophysiology, especially in severe cases, involves the right side of the heart. This can lead to pulmonary hypertension, right ventricular dysfunction, and even RV microinfarction, as depicted in Figure 279-6. How does this dangerous cascade begin?
Absolutely critical. The pulmonary artery obstruction caused by the embolus, coupled with the release of those neurohumoral mediators we mentioned, leads to a significant rise in pulmonary artery pressure and pulmonary vascular resistance.
Okay.
This forces the right ventricle, which is normally a relatively thin-walled chamber used to pumping against low pressure, to work much, much harder. This causes a dramatic increase in its wall tension.
This increased strain sounds like it could trigger a series of really bad events for the heart.
It does. When that RV wall tension rises sharply, the right ventricle responds by dilating or enlarging and becoming dysfunctional. It just can't cope. This abnormal stretch of the RV wall also triggers the release of cardiac biomarkers, notably brain natriuretic peptide, or BNP, which is a clear sign of heart muscle stretch and strain.
And how does the stressed right ventricle then impact the left side of the heart, the side responsible for pumping blood to the rest of the body?
Right, this is key. The stressed and enlarged right ventricle starts to physically impact the left side. The interventricular septum, the wall separating the two ventricles, can bulge into and compress the normally functioning left ventricle. This reduces the left ventricle's ability to distend properly during filling. Its diastolic function is impaired. This directly impacts systemic blood flow and can lead to systemic hypotension or low blood pressure.
So the right side is struggling, and it's physically squishing the left side. But it sounds like the right ventricle itself can suffer even more direct damage too.
Indeed. That increased RV wall tension can also compress the right coronary artery, which supplies blood to the right ventricular muscle itself.
Oh, wow.
This limits the myocardial oxygen supply, potentially precipitating right ventricular ischemia, a lack of blood flow and oxygen, and in severe cases, RV microinfarction, like a tiny heart attack in the right ventricle. This in turn leads to the release of additional cardiac biomarkers, like troponin.
And what's the ultimate, most life-threatening consequence of this entire cascade?
The ultimate and most life-threatening consequence is circulatory collapse. The underfilling of the left ventricle caused by the RV dysfunction and that septal shift can lead to a drastic fall in left ventricular cardiac output and systemic arterial pressure.
Yeah.
This can rapidly progress to circulatory collapse and, tragically, death. If we connect this to the bigger picture, this whole cascade explains the profound severity of what we call massive PE. It underscores the critical importance of early, aggressive intervention focused on supporting that struggling right ventricle to prevent this systemic failure. It's truly a race against time.
Okay, moving from the how, the pathophysiology, to the what. Let's explore how clinicians categorize these conditions. Why do these classifications matter so much?
Well, understanding the severity and location of DVT and PE is absolutely fundamental because it directly guides treatment decisions and informs the patient's prognosis, their likely outcome.
Let's start with pulmonary embolism, PE classification. There are essentially three categories based on severity.
That's right. The most severe is massive PE, also called high-risk PE. This accounts for about 5–10% of cases.
Okay, relatively small percentage, but high risk.
Exactly. It's characterized by systemic arterial hypotension, dangerously low blood pressure, and usually extensive thrombosis, affecting at least half of the pulmonary vasculature. The hallmarks are classic signs of severe distress, dyspnea, shortness of breath, syncope, fainting, hypotension, and cyanosis, that bluish discoloration from lack of oxygen.
Yeah.
Patients with massive PE may present in full cardiogenic shock, where the heart simply can't pump enough blood. They're at very high risk, can die from multisystem organ failure. Needs immediate action.
And what about the next level down, what's called submassive PE?
Next is submassive PE, or intermediate risk PE. This category accounts for maybe 20–25% of patients. Here, the defining characteristic is evidence of right ventricular dysfunction, despite the patient having normal systemic arterial pressure.
So their BP is okay for now, but the right heart is struggling.
Precisely. That combination of right heart strain or failure, often confirmed by imaging or biomarkers like troponin, indicates a high risk of clinical deterioration, even without immediate low blood pressure. They're unstable, even if their BP hasn't dropped yet.
And finally, the most common and less severe category.
That'll be low-risk PE. This constitutes the majority, about 65–75% of cases. These patients generally have an excellent prognosis and typically recover well with standard anticoagulation or blood thinners. These classifications are absolutely critical, as I said, because they immediately inform the urgency and the potential invasiveness of the required treatment. Massive PE needs immediate, often aggressive intervention, whereas low-risk PE can usually be managed effectively with anticoagulation alone, sometimes even as an outpatient.
Now, let's turn our attention to deep venous thrombosis, DVT classification, which is primarily based on its location.
Lower extremity DVT is by far the most common, occurring roughly 10 times more frequently than upper extremity DVT.
10 times? Wow.
Yeah. It usually begins down in the calf veins and can then propagate proximally upwards to involve the popliteal vein behind the knee, the femoral vein in the thigh, and even the iliac veins in the pelvis. Generally speaking, the more proximal the clot, the closer to the torso, the higher the risk of it breaking off and causing a significant PE.
And what about upper extremity DVT? Is that triggered by different factors usually?
Upper extremity DVT, while less common, is often precipitated by specific medical interventions. Think placement of pacemakers, internal cardiac defibrillators, ICDs, or indwelling central venous catheters, like PICC lines or other central lines. The likelihood of developing an upper extremity DVT seems to increase with both the catheter's diameter and the number of lumens or channels it has. It highlights a clear risk associated with these often necessary medical devices.
What about clots closer to the surface, in the superficial veins? Is that as serious?
Superficial venous thrombosis is a clot in a vein close to the skin. It typically presents with localized redness, erythema, tenderness, and often a palpable cord. You can actually feel the hardened vein under the skin.
Right.
While often less immediately dangerous than a DVT, patients with superficial vein thrombosis are still at risk for the clot extending into the deeper venous system. If that happens, it becomes a DVT and carries the risk of PE. So it still needs careful attention and management.
So what's the practical takeaway from all these classifications for you as a patient, or maybe someone trying to identify symptoms in a loved one?
These classifications are absolutely vital. They directly guide treatment decisions and provide crucial information about likely outcomes. A massive PE requires immediate aggressive intervention. A low-risk PE can often be managed less intensively, but still needs critical care. Similarly, the location and extent of a DVT influence the choice and duration of therapy. Understanding these categories is really the first step toward effective management and understanding your prognosis or the prognosis of someone you care about.
Okay, let's move into diagnosis. DVT and PE are notoriously difficult to diagnose, right? PE often gets called the great masquerader.
That's a very common term for it, yes. The diagnosis is difficult precisely because the symptoms and signs are so nonspecific, they often mimic other common conditions.
Yeah.
And this nonspecificity, unfortunately, sometimes leads to, well, excessive ordering of diagnostic tests. In the United States, for instance, there appears to be a significant reliance, maybe an over-reliance, on computed tomography, pulmonary angiograms, CT scans of the chest in patients suspected of PE.
And our sources give a concrete example of this potential overtesting. One study looked at 1.8 million patient encounters across 27 emergency departments. 5% of those patients got a CT pulmonary angiogram.
5% is a lot.
Yeah. And while increased D-dimer levels did correlate with a better diagnostic yield, What's the main concern with this high volume of scans?
The sheer volume suggests that many of these scans might not have been strictly necessary based on pretest probability. This creates both a significant cost burden on the healthcare system and, importantly, exposes patients to unnecessary radiation. It really highlights the need for more targeted, risk-stratified diagnostic approaches.
One of the key blood tests used in the workup for VTE is the D-dimer test. How does it work and what does it actually tell us?
Okay, so the quantitative plasma D-dimer ELISA test measures a protein fragment that's produced when a blood clot is broken down by the body's natural clot-dissolving system, involving an enzyme called plasmin. So an elevation indicates endogenous thrombolysis, basically. The body is trying to dissolve a clot somewhere.
Okay.
Its sensitivity is quite high, greater than 80% for DVT, including isolated calf DVT, and over 95% for PE. It's slightly less sensitive for DVT, likely due to the generally smaller size of the thrombus compared to PE.
So a normal D-dimer is incredibly useful then. It's a good rule-out test for PE, right? If it's negative, PE is highly unlikely.
Exactly. That's its main strength.
But you also mentioned it lacks specificity. What does that mean in practical terms? Why isn't it useful for everyone?
It means D-dimer levels can increase in a whole wide array of conditions completely unrelated to VTE. Things like a heart attack, myocardial infarction, pneumonia, sepsis, cancer, simply being postoperative, or even just being in the second or third trimester of pregnancy.
Ah, okay. Lots of things.
Lots of things. Because of this lack of specificity, the D-dimer test rarely has a useful role among hospitalized patients because their levels are frequently elevated just due to their underlying systemic illness.
So for outpatients, how do we use D-dimer more effectively to try and avoid unnecessary imaging, like those CT scans?
Well, for patients older than 50 years who have a low or intermediate clinical probability of PE based on scoring systems, we'll discuss current guidelines, now recommend using an age-adjusted D-dimer cutoff.
Age-adjusted, how does that work?
You calculate the upper limit of normal by simply multiplying the patient's age by 10. So for a 70-year-old patient, the upper limit would be 700 nanograms per milliliter instead of the standard, say, 500.
Okay.
This age-adjusted approach, crucially, does not apply if you suspect acute DVT, only PE. But validation studies have shown its routine use can reduce the number of CT pulmonary angiograms ordered by about a third.
A third? That's significant.
It is. It helps strike that delicate balance avoiding overtesting while making sure critical diagnoses aren't missed.
When it comes to symptoms, PE is often challenging because it presents so nonspecifically. But what's often cited as the most common symptom of PE?
Unexplained breathlessness is usually the most common symptom, just feeling short of breath without a clear reason.
Okay.
And it's often subtle, which contributes to the diagnostic difficulty. A really critical clinical clue, though, can arise when an occult or hidden PE occurs alongside another overt condition, like congestive heart failure or pneumonia.
Right.
In those scenarios, the patient often just fails to improve clinically despite getting standard medical treatment for the recognized illness. That failure to improve should strongly raise suspicion for the possible coexistence of a PE. It's a red flag.
And for DVT, what's the most common symptom and what makes it maybe distinct from just a typical muscle cramp?
The most common symptom for DVT is usually a cramp, or what people often describe as a Charlie horse in the lower calf. What differentiates it, though, is that this discomfort typically persists and intensifies over several days, rather than resolving quickly like a simple muscle cramp would.
The persistence is key.
Persistence and worsening, yes. It's a subtle but important distinction.
To help clinicians estimate the clinical likelihood of DVT and PE, our sources discuss a tool called the Wells Point Score. What's its purpose? How does it help?
The Wells Point Score, which is detailed in Table 279.2, is an incredibly valuable clinical prediction rule. It uses specific clinical variables, things like signs of DVT, whether PE is the most likely diagnosis, heart rate, recent surgery or immobilization, history of VTE, hemoptysis, coughing up blood, or malignancy to stratify a patient's risk into low, intermediate, or high likelihood of having DVT or PE.
Okay, so it gives you a probability score.
Exactly. And based on those scores, figure 279.7 in the source shows us a diagnostic algorithm. How does that guide the next steps?
Right, it's quite streamlined. Patients with a low likelihood of DVT or a low to moderate likelihood of PE, according to their Wells score, should undergo initial diagnostic evaluation with D-dimer testing alone.
Just the blood test first.
Right. If that D-dimer test result is negative, then generally no obligatory imaging tests are needed to rule out VTE. You can be reasonably confident.
Yeah.
However, if a patient presents with a high clinical likelihood of VTE based on the score, they should actually skip D-dimer testing altogether and proceed directly to imaging as the next step. The pretest probability is high enough that a negative D-dimer wouldn't be reassuring enough, and a positive one is expected anyway.
Makes sense. Go straight to the scan if suspicion is high.
Now let's talk about some crucial clinical pearls and the extensive differential diagnosis as outlined in Table 279-3 for both DVT and PE. The key insight here, as our sources really emphasize, is that not all leg pain is DVT, and certainly not all dyspnea is PE. This is where a clinician's ability to think broadly becomes absolutely paramount.
Absolutely. Differential diagnosis is huge here. For things that mimic DVT, sudden severe calf discomfort often suggests a ruptured Baker's cyst that's a fluid-filled sac behind the knee rather than a clot. Fever and chills usually point towards cellulitis, a skin infection, rather than DVT. Another interesting mimic is recurrent left thigh edema, particularly in young women. That should raise suspicion for May-Thurner syndrome, where the right iliac artery compresses the left iliac vein. And if the leg is diffusely edematous, very swollen all over, DVT is actually less likely. An acute exacerbation of chronic venous insufficiency due to post-thrombotic syndrome is more probable in that case. For upper extremity venous thrombosis, sometimes asymmetry in the supraclavicular fossa, the hollow above the collarbone, or just measuring the upper arm circumference can be a clue.
That list of DVT mimics really highlights the complexity. And for PE mimics, it's an even longer list, isn't it?
Yeah.
Underscoring why it's called the Great Masquerader. What are some of the common conditions that can present very similarly to PE?
Oh, the link for PE mimics is extensive. You've got pneumonia, asthma, COPD exacerbation, congestive heart failure, pericarditis, inflammation of the heart sac, pleurisy, often from viral syndromes. Then there's musculoskeletal discomfort, like costochondritis, rib fractures, pneumothorax, a collapsed lung, acute coronary syndrome, a heart attack, anxiety or panic attacks, and even vasovagal syncope, fainting.
Wow, that's a lot to roll out.
It really is. This list underscores the critical importance of considering these differential diagnoses carefully to avoid misdiagnoses, which can obviously have life-threatening consequences. It demands a broad and careful clinical perspective.
And within the PE context itself, you mentioned pulmonary infarction. What exactly is that, and why is it often described as being so painful?
A pulmonary infarction usually indicates a smaller PE, where a clot lodges more peripherally out towards the edge of the lung. This condition is often exquisitely painful because the thrombus lodges near the innervation of the pleural nerves, the nerves lining the lung and chest wall.
Nerve involved.
Exactly. It's a good example of how the size of the PE doesn't always correlate directly with the intensity of the pain. Smaller peripheral ones can hurt more due to that pleural irritation.
And beyond blood clots, our sources also mention various non-thrombotic PE etiologies. What are some of these other things that can embolize to the lungs besides bits of blood clot?
Right. It's not always a blood clot. You can have fat embolism, which can occur after pelvic or long bone fractures when fat globules from the marrow enter the bloodstream.
Okay.
There's also tumor embolism, bone marrow embolism, air embolism, often from IV lines or procedures. Less common, but still important, are cement embolism or bony fragment embolism, which can sometimes happen after total hip or knee replacement surgery.
Cement embolism.
Yeah, from the cement used to fix the joint. And disturbingly, intravenous drug users may inadvertently inject a wide array of substances, things like hair, talc, cotton, which can then embolize to the lungs. And finally, amniotic fluid embolism is a rare but very severe obstetrical complication that occurs when fetal membranes leak or tear during pregnancy or delivery, releasing amniotic fluid into the mother's circulation.
Okay, moving on from clinical evaluation and the differentials, let's explore the non-imaging diagnostic modalities that can give us further clues about potential DVT and PE. What insights do cardiac biomarkers provide?
Two key areas here involve elevated cardiac biomarkers. Serum troponin levels and plasma heart-type fatty acid-binding protein levels can increase. This is due to that right ventricular microinfarction we discussed earlier, the damage to the RV muscle caused by strain from the PE.
Right, the troponin.
Exactly. Additionally, that myocardial stretch, also a result of RV dysfunction, causes the release of brain natriuretic peptide, or BNP, and its precursor, NT-proBNP. These biomarkers provide objective evidence of cardiac strain and damage, helping to identify higher-risk PE patients, even if their blood pressure is stable.
The electrocardiogram, or ECG, can also offer some insights, though maybe not definitively diagnostic. What are the common findings there?
Well, while sinus tachycardia, just a test heart rate, is the most frequently cited abnormality on ECG and PE, there's also the classic S1Q3T3 sign.
S1Q3T3, what is that?
It involves seeing an S wave in lead Y, a Q wave in lead 3, and an inverted T wave in lead 3. You can see it in figure 279-8. This finding is relatively specific for PE, meaning if you see it, PE is more likely, but it's actually quite insensitive. Many, maybe most, PE patients won't exhibit it.
Okay, so not very reliable on its own.
Not highly reliable. The most common ECG abnormality, however, is actually E wave inversion in the precordial leads, specifically V1 to V4. This pattern indicates right ventricular strain and ischemia, reflecting that increased workload and oxygen demand on the right side of the heart due to the pulmonary obstruction.
Now let's delve into the non-invasive imaging modalities, which are crucial for getting a more definitive diagnosis. Starting with venous ultrasonography for DVT, how does it primarily work? What's the main principle?
Venous ultrasonography is really the primary tool for diagnosing DVT in the legs or arms. It relies on a simple yet effective principle: loss of vein compressibility.
Loss of compressibility.
Yeah. When a normal vein is imaged in cross-section with the ultrasound probe, gentle manual pressure from the probe causes the vein to readily collapse. It creates the illusion of a wink on the screen. With an acute DVT, the vein loses this compressibility because it's passively distended by the acute thrombus inside it. It won't collapse when you push.
Ah, okay. Simple but effective. And what does the clot itself look like on ultrasound?
Well, the diagnosis is even more secure when the thrombus can be directly visualized. It typically appears homogeneous kind of uniform and has low echogenicity, meaning it looks dark or slightly gray on the screen. The affected vein often appears mildly dilated compared to the artery next to it, and collateral channels, those alternative routes for blood flow, may be absent initially. Doppler imaging, which assesses blood flow, adds further information. You look for loss of the normal respiratory variation in flow, or absent augmentation, meaning the flow doesn't speed up when you squeeze the calf, both of which indicate an obstruction upstream. If the ultrasound is technically poor or non-diagnostic, then alternative imaging like CT or MRI venography should be considered.
Now, for chest röntgenography or a standard chest X-ray, it's often normal or nearly normal in patients with PE, which can be misleading, right?
That's a key point. A normal chest X-ray absolutely does not rule out PE. In fact, it's probably the most common finding.
But what are some of the classic abnormalities that can sometimes be present, even if they're not always seen?
Well, while often normal, some well-established, though less common, abnormalities can be present. These include focal allogemia, an area of decreased blood flow appearing as a lucency or darker area on the X-ray that's known as Westermarck's sign.
Westermarck's sign, okay.
There's also sometimes a peripheral wedge-shaped density, usually located right at the pleural base, called Hampton's hump. That suggests pulmonary infarction tissue death due to lack of blood flow.
Hampton's hump. Got it.
And sometimes you might see an enlarged right descending pulmonary artery, which is called Pallas sign. That can indicate right heart strain due to the PE. But again, these are relatively insensitive findings.
Chest CT with intravenous contrast, the CT pulmonary angiogram, or CTPA, has really become the principal imaging test for PE diagnosis now. What makes it so effective?
The CTPA, as brilliantly illustrated in figure 279-10A, provides truly exquisite detail. Modern scanners have resolutions as fine as 1 millimeter or even less.
Wow.
This allows visualization of very small sixth-order branches of the pulmonary arteries, which is actually superior in resolution to conventional invasive pulmonary angiography, the old gold standard.
Better than the invasive test.
In terms of resolution, yes. And critically, the CT scan also provides an excellent four-chamber view of the heart, as you can see in figure 279-10B. Right ventricular enlargement seen on the chest CT is a significant prognostic indicator. It signals an increased likelihood of death within 30 days compared with PE patients who have a normal RV size.
So it diagnoses and gives prognostic info.
Exactly. And furthermore, in patients who turn out not to have PE, the lung parenchymal images, the pictures of the lung tissue itself, can often establish alternative diagnoses that weren't apparent on the chest X-ray. Things like pneumonia, emphysema, pulmonary fibrosis, pulmonary mass, or even aortic pathology like dissection can sometimes be picked up, explaining the patient's symptoms.
Lung scanning, or a VQ scan, is often used as a second-line diagnostic test for PE. When is it typically chosen over a CT scan?
It's primarily reserved for patients who cannot tolerate intravenous contrast dye, perhaps due to significant kidney issues or a severe allergy, which would preclude getting a contrast-enhanced CT scan.
Okay. How does it work?
Well, the perfusion scan, the Q part, involves injecting small particulate aggregates of albumin labeled with a gamma-emitting radionuclide intravenously. These tiny particles get trapped in the pulmonary capillary bed.
Right.
The perfusion scan then identifies defects areas where the radioactive tracer isn't taken up, indicating absent or decreased blood flow, which could be due to PE.
Okay, but how do you know it's PE and not something else causing the defect?
That's where the ventilation scan, the V part, comes in. To improve specificity, ventilation scans are performed using a radio-labeled inhaled gas like xenon or krypton. Abnormal ventilation scans indicate areas of non-ventilated lung, thereby providing possible explanations for perfusion defects other than acute PE. Things like asthma or COPD can cause abnormal ventilation.
So you compare the V and the Q.
Exactly. The diagnosis of PE is very unlikely with completely normal scans. Conversely, it's about 90% certain with what's called a high probability scan, where you have perfusion defects in areas with normal ventilation, a VQ mismatch.
Magnetic resonance, or MR, imaging with contrast also has a role, doesn't it? How is it used for DVT?
Yes. When venous ultrasound is equivocal, meaning the results are unclear or technically limited. MR venography with gadolinium contrast is an excellent alternative modality to diagnose DVT. It gives very clear pictures of the veins.
But is it as good as CT for actually detecting PE in the lungs?
Generally, no. MR pulmonary angiography is more limited in that respect. While it may detect large proximal PEs clots in the main pulmonary arteries, it's generally not considered reliable for detecting smaller segmental and subsegmental PEs further out in the lungs.
Well,
CTPA remains the preferred modality for direct visualization of the pulmonary arteries for PE.
echocardiography ultrasound of the heart is surprisingly not considered a reliable primary diagnostic tool for acute PE itself. Why is that?
It's because most patients with PE actually have normal echocardiograms, especially if the PE isn't massive or causing significant right heart strain. So a normal echo cannot reliably rule out PE.
Okay. But it is useful for other things.
Yes, it's very useful for detecting other conditions that might mimic PE clinically. Things like an acute myocardial infarction, pericardial tamponade, fluid compressing the heart, or aortic dissection. It's good for those differentials.
Does it ever show the clot directly?
Transthoracic echocardiography, the standard echo probe on the chest wall, rarely images the thrombus directly in the pulmonary arteries. The best known indirect sign of PE on transthoracic echo is something called McConnell's sign.
McConnell sign.
Yes, that's where you see hypokinesis, or reduced motion, of the right ventricular free wall, but with normal or even hyperkinetic motion of the RV apex, the very tip of the right ventricle. It's suggestive, but not perfectly specific.
I see.
Transesophageal echocardiography, or TE, where the probe goes down the esophagus for a closer look at the heart, can sometimes be considered if CT scanning isn't available or if a patient has severe renal failure or contrast allergy. TE can sometimes identify large saddle, right main, or left main PEs more readily than transthoracic echo.
Finally, let's briefly touch upon the invasive diagnostic modalities, like pulmonary angiography, which have largely been supplanted by the non-invasive options now. What's its current role?
Pulmonary angiography, which used to be the gold standard, has really been virtually replaced by chest CT with contrast, CTPA, for routine diagnosis. Invasive catheter-based diagnostic testing is now generally reserved for patients with technically unsatisfactory or indeterminate chest CTs, or perhaps for those patients in whom an interventional procedure, like catheter-directed thrombolysis, is being planned concurrently.
And what defines a PE on angiography?
A definitive diagnosis of PE with angiography requires direct visualization of an intraluminal filling defect, seeing the clot inside the vessel in more than one projection. There are also secondary signs like an abrupt vessel occlusion, cutoff, segmental oligemia or vascularity, areas of reduced or absent blood flow, a prolonged arterial phase with slow filling and tortuous tapering peripheral vessels.
And what about contrast phlebography for DVT? Is that still used much?
Similarly, contrast phlebography, which involves injecting contrast dye directly into the leg veins, has also virtually been replaced by venous ultrasonography as the principal diagnostic test for suspected DVT.
Yeah.
It's now typically only used if an interventional procedure, like catheter-based DVT treatment, is planned that requires detailed visualization of the venous anatomy.
Okay, so to tie all these complex diagnostic pieces together, our source presents an integrated diagnostic approach, nicely summarized in Figure 27911. What's the most important takeaway from looking at that flowchart? How does it help clinicians?
Well, if we connect this to the bigger picture, that flowchart really emphasizes how clinical likelihood, assessed using tools like the Wells score, combined with D-dimer results, and then the appropriate choice of imaging, are all carefully streamlined to optimize the diagnostic process.
Right.
It's designed to minimize unnecessary testing, like avoiding CT scans in low-risk patients with a negative D-dimer, while ensuring that critical diagnoses are made efficiently and accurately in higher-risk patients. It's really a pragmatic, step-by-step decision-making pathway that helps clinicians navigate the inherent complexity of VTE diagnoses effectively.
Okay, so once diagnosed, the treatment decisions for DVT and PE become multifaceted and often quite complex. Let's break down the strategies, starting with therapy specifically for deep venous thrombosis, DVT.
Right. For DVT, primary therapy often focuses on clot dissolution, typically using pharmacomechanical therapy. This usually involves low-dose catheter-directed thrombolysis, where medication is delivered right to the clot via a catheter, sometimes with mechanical disruption of the clot as well.
And there's this idea called the open vein hypothesis.
Yes, the open vein hypothesis posits that patients who receive this kind of primary aggressive clot-dissolving therapy will sustain less long-term damage to their venous valves. The theory is that this should lead to lower rates of post-thrombotic syndrome down the road.
But the results of a major trial, the ATTACTOR trial, introduced some important nuance to this, didn't they? What did that trial reveal?
That's right. The ATTRACT trial was a large randomized study involving almost 700 patients with extensive DVT, specifically femoral or iliofemoral clots. It compared catheter-directed thrombolysis against usual care, which is anticoagulation alone.
And the results?
Well, after 2 years, there was no overall reduction in post-thrombotic syndrome in the group that got thrombolysis compared to the anticoagulation-only group.
Oh, so it didn't help overall.
Not overall. However, and this is a critical nuance, there was a trend towards less post-thrombotic syndrome at 2 years, specifically for the subgroup of patients with iliofemoral DVT. Those are the more extensive clots involving the veins in the thigh and pelvis.
Ah, so maybe it helps for the biggest clots.
That's the suggestion. It highlights that the benefit might be localized to more extensive proximal DVT, where dissolving the clot quickly might indeed prevent more significant long-term damage to the venous valves in those larger veins. Less clear benefit for clots lower down.
That distinction between proximal and distal clots seems really important. You also mentioned earlier the risks associated even with asymptomatic DVT. What did that APEX trial sub-study find again?
It found that patients with asymptomatic DVT clots, found incidentally maybe on screening that aren't causing noticeable symptoms, actually had a 3-fold higher mortality rate than similar hospitalized patients without DVT.
3-fold higher death rate.
Yes. It really emphasizes that even undetected clots can have serious long-term consequences. It underscores the silent danger of these conditions.
When it comes to upper extremity DVT, often associated with things like PICC lines, what can be done to prevent them? Are there practical steps?
Yes. The rate of upper extremity DVT can likely be decreased through more judicious patient selection for PICCs in the first place. Also, simple things like opting for single lumen rather than double or triple lumen PICCs when possible, and using the smallest possible lumen size, ideally 4 French diameter rather than 5 or 6 French, can significantly reduce the risk. These are important practical considerations for clinicians placing these lines.
And what about isolated calf DVT? It sounds like it might be underestimated sometimes. What did that Garfield VT registry tell us? Does it matter if it's just in the calf?
Right. Isolated calf DVT, despite being distal, really shouldn't be underestimated. The Garfield VT registry, which compared over 2,000 patients with isolated calf DVT to nearly 4,000 with proximal DVT, revealed some interesting distinctions.
Like what?
Well, those with calf DVT were more likely to have had recent surgery or leg trauma, and maybe less likely to have active cancer or a prior history of VTE compared to the proximal group. Almost all these patients received anticoagulation, nearly half, for at least a year.
Okay.
But what's fascinating here is that in a smaller study, the 10-year mortality for isolated calf DVT was actually the same as for proximal leg DVT.
The same mortality. Wow.
Yeah. And furthermore, cancer-associated isolated calf DVT had just as high a recurrence rate as cancer-associated proximal leg DVT. So this really shows that the term isolated doesn't necessarily imply a lower risk or less need for potentially aggressive management, especially in certain patient populations like those with cancer. They shouldn't just be dismissed as minor events.
Okay, for secondary prevention of DVT, preventing another one, the main methods are anticoagulation or placing an inferior vena cava or IVC filter. When are IVC filters typically indicated? It sounds like not very often.
They're generally reserved for very specific situations, primarily in patients who have an absolute contraindication to anticoagulation, meaning they absolutely cannot take blood thinners, usually due to a very high bleeding risk.
Okay.
Or for those unfortunate patients who experience recurrent venous thrombosis despite already being on therapeutic doses of anticoagulation, so anticoagulation failure.
Right.
They're generally not indicated for the primary prevention of VTE in most patients.
And if an IVC filter is placed, is it usually permanent?
Ideally, no. It's important that if an IVC filter is placed, it should ideally be retrieved once the clinician determines the patient no longer requires it, if possible. Retrievable filters are often preferred now.
And what about graduated compression stockings? Do they help prevent long-term problems like post-thrombotic syndrome?
Well, while they may be prescribed symptomatically for leg swelling and acute DVT, the source explicitly states that their routine prescription in asymptomatic, newly diagnosed acute DVT patients does not appear to prevent the development of post-thrombotic syndrome long-term. That clarifies a common misconception about their preventative efficacy.
Okay, now let's shift our focus to pulmonary embolism, or PE therapy. Risk stratification seems absolutely paramount here. What indicators point to a high risk for adverse outcomes, even with treatment?
For risk stratification in PE, as shown clearly in Figure 279.12, we look for key indicators of a high risk of an adverse clinical outcome, even when the patient is on anticoagulation. These include hemodynamic instability, that dangerously low blood pressure.
Right, massive PE.
Right. But also signs of right ventricular dysfunction on echocardiography or RV enlargement seen on the chest CT scan or elevation of the troponin level indicating RV microinfarction. Any of these portend a high risk of deterioration.
Okay.
Conversely, if the right ventricular function remains normal in a hemodynamically stable patient, a good clinical outcome is highly likely with anticoagulation alone. That's the low-risk group.
Effective anticoagulation blood thinners is truly the foundation for successful treatment of both DVT and PE. Our sources outline 3 major strategies, and Table 279.4 provides a really detailed breakdown of the various agents. What are those 3 main strategies?
Okay, the first sort of classical strategy, which is definitely waning now, involves parenteral anticoagulation, meaning injected using unfractionated heparin, UFH, low molecular weight heparin, LMWH, or fondaparinux, which is then bridged to warfarin, the oral medication.
Bridged. Okay.
The second strategy involves initial parenteral therapy, which is then switched after about 5 days or so to one of the novel oral anticoagulants, or NOACs, specifically dabigatran, which is a direct thrombin inhibitor, or edoxaban, which is an anti-EXA agent.
So parenteral then switched to oral.
Right. And the third and increasingly popular strategy is oral anticoagulation monotherapy right from the start, using either rivaroxaban or apixaban. Both of those are anti-EXA agents. This typically involves a higher loading dose for the first few days or weeks, followed by a lower maintenance dose.
Simpler. No injections needed usually.
Generally, yes. And just briefly, for patients who develop VTE in the setting of suspected or proven heparin-induced thrombocytopenia, HIT, that rare but serious side effect of heparin, there are alternative parenteral direct thrombin inhibitors available, argatroban and bivalirudin.
Let's delve into these specific anticoagulants a bit more, starting with the classic unfractionated heparin, or UFH. How does it work?
Unfractionated heparin, UFH, works by binding to and accelerating the activity of antithrombin, which is a natural anticoagulant protein. This prevents additional thrombus formation. It doesn't really dissolve existing clot much.
Okay. And how is it dosed?
It's dosed based on weight and adjusted to achieve a target-activated partial thromboplastin time, or APTT, which is a blood test measuring clotting time. The target is usually 60-80 seconds. Typically, there's an initial intravenous bolus dose, followed by a continuous infusion rate, which needs frequent monitoring and adjustment based on the APT results.
What's the main advantage of using UFH, given it needs all that monitoring?
The main advantage of UFH is its very short half-life. This is particularly useful when you need hour-to-hour control of anticoagulation intensity, for example. If a patient is unstable, might need an urgent procedure, or if there's a concern about bleeding, you can turn it off, and its effect wears off relatively quickly.
Okay.
Heparin also seems to have some beneficial pleiotropic effects, meaning actions beyond just anticoagulation, like potentially decreasing systemic and local inflammation.
Next are the low molecular weight heparins, or LMWHs, like enoxaparin. What makes them different from UFH, and what are their advantages?
Right, LMWHs are basically fragments of unfractionated heparin. They exhibit less binding to plasma proteins and endothelial cells compared to UFH. Consequently, they have greater bioavailability, a much more predictable dose response, and a longer half-life.
So less monitoring needed.
Exactly. These advantages mean that typically no routine laboratory monitoring or dose adjustment is needed for LMWH in most patients, unless someone is markedly obese or has significant chronic kidney disease. A common example is enoxaparin, often dosed subcutaneously under the skin at 1 mg/kg twice daily. Much simpler administration.
Then there's fondaparinux. You described it as an anti-GUSA pentasaccharide. What makes it unique?
Fondaparinux is essentially an ultra-low molecular weight synthetic heparin derivative. It's administered as a simple weight-based once-daily subcutaneous injection, often in a pre-filled syringe. What's truly unique about fondaparinux is that, like LMWH, no routine lab monitoring is required. It's synthesized in a lab, so it's not derived from animal products, which can be important for some patients. And crucially, it does not cause heparin-induced thrombocytopenia, HIT.
Oh, that's a big advantage.
It is. However, its dose must be adjusted downward or it might be contraindicated in patients with significant renal dysfunction.
Then we have warfarin, probably the most well-known oral anticoagulant for a long time. How does it function and how long does it take to really kick in?
Warfarin is a vitamin K antagonist. It works by preventing the carboxylation-dependent activation of several key coagulation factors, specifically factors 2 prothrombin, 7 IX, and X. These factors need vitamin K to become active in the clotting cascade.
Right.
Its full anticoagulant effect takes time to achieve, usually at least 5 days of daily therapy. This is because it works by depleting the existing active factors, which have varying half-lives, and that takes time.
This is why it requires that bridging therapy you mentioned earlier when starting it. How does that bridging process work exactly?
Yes, bridging is absolutely essential when starting warfarin for acute VTE. You need to overlap warfarin with a faster-acting parenteral anticoagulant like UFH, LMWH, or fondaparinux for at least 5 days.
Okay, 5 days minimum overlap.
Minimum 5 days, and you continue the parenteral agent until 2 sequential INR values, the international normalized ratio, which measures warfarin's effect measured at least 1 day apart, achieve the target therapeutic range, which is typically 2.0 to 3.0.
Okay, so INR needs to be therapeutic for 2 days straight before stopping the injectable.
Correct. The usual starting dose for warfarin is often 5 mg daily, but it needs careful titration based on frequent INR monitoring initially.
Now, warfarin, despite its long history and effectiveness, comes with significant challenges, doesn't it? What are some of the practical difficulties for patients and clinicians?
Oh, it's quite complex to manage. There are literally hundreds of potential drug-food interactions, even things like leafy green vegetables, high in vitamin K, that can affect its metabolism and effectiveness, making dose management tricky. It carries a significant risk of major hemorrhage, including potentially devastating intracranial hemorrhage, even when the INR is technically within the desired therapeutic range. And it can have some off-target side effects like alopecia, hair loss, or contributing to arterial vascular calcification over the long term.
Despite these challenges, there have been improvements in managing warfarin over the years, right?
Thankfully, yes. The development of centralized anticoagulation clinics with dedicated pharmacists or nurses has significantly improved the efficacy and safety of warfarin dosing through close monitoring and patient education.
Yeah.
Some patients can even self-monitor their INR with home point-of-care fingerstick machines now, and a select few can even be taught to self-dose their warfarin based on algorithms, which really empowers them in their own care and can improve adherence.
And finally, we have the novel oral anticoagulants, or NOACs, sometimes called DOACs, direct oral anticoagulants. These are often described as a real game changer in VTE treatment. What are their key advantages over warfarin?
The NOACs, which include the factor Zeta inhibitors, rivaroxaban, apixaban, and edoxaban, and the direct thrombin inhibitor dabigatran, represent a significant advancement for many, many patients.
How so?
Well, their main advantages are that they are administered in a fixed dose, they establish effective anticoagulation within just hours of ingestion, and crucially, they require no routine laboratory coagulation monitoring like the INR for warfarin.
No regular blood tests. That's huge for patients.
It's a massive advantage for quality of life. Patients also don't need to restrict eating green leafy vegetables, as these drugs don't interact with vitamin K, and they have relatively few significant drug interactions compared to warfarin.
So, okay, let's unpack the practical implications. These seem much simpler to use.
They are much simpler. The practical implications of these various drug choices, especially regarding patient compliance and safety, are huge. NOACs, with their simpler dosing, rapid onset, and fewer interactions, have significantly eased the burden of long-term anticoagulation for many patients and clinicians. Warfarin, however, still plays a vital role, especially in patients with severe kidney disease, mechanical heart valves, or antiphospholipid syndrome, but it requires that more intensive monitoring and patient education. So the choice depends on the individual patient.
Effective management of bleeding, if it occurs while on anticoagulants, is just as important as the anticoagulation itself. What are the specific reversal agents available for these different classes of drugs? We need ways to turn them off quickly in an emergency.
Absolutely. Having reversal agents is critical for safety. For life-threatening or intracranial hemorrhage caused by heparin or LMWH, the specific reversal agent is protamine sulfate.
Okay, protamine for heparins?
For dabigatran, the direct thrombin inhibitor, there's a specific antibody called idarucizumab, which is an effective and very rapidly acting antidote.
Idarucizumab for dabigatran. Got it.
And for the oral factors, ACE inhibitors, rivaroxaban, apixaban, doxaban, there is andexanet alpha available to reverse bleeding complications.
Indexanet for the AZER inhibitors. Okay. And for warfarin, how is bleeding managed there? Still vitamin K?
For warfarin, the management depends on the severity. Major life-threatening bleeding is best managed rapidly with prothrombin complex concentrate, or PCC, which quickly replenishes the vitamin K-dependent clotting factors.
PCC for major warfarin bleeds.
Right. For less serious bleeding, fresh frozen plasma, FFP, or intravenous vitamin K can be used. And for minor bleeding or very high INR without bleeding, oral vitamin K is often effective.
So, the availability of these specific reversal agents must make clinicians more comfortable using these potent drugs.
Immensely so. The development and availability of these specific reversal agents has dramatically improved the safety profile of anticoagulation therapy overall. It allows for more confident and sometimes more aggressive treatment of VTE, knowing that there are effective ways to manage bleeding risks if they arise. It's been a huge step forward in patient safety.
Now, when venous thromboembolism occurs in patients who also have cancer, the treatment approach often needs specific considerations. What's generally recommended for these complex patients?
For patients with active cancer and VTE, the current recommendation is generally to prescribe either LMWH as monotherapy daily injections or one of the NOACs, like apixaban or rivaroxaban.
Okay.
There's a slight caution with NOACs if the patient has a gastrointestinal cancer, as some studies suggested a potentially higher risk of GI bleeding compared to LMWH in that specific setting, though newer data are evolving.
And how long do they typically stay on anticoagulation?
The anticoagulation is typically of extended duration, often continuing indefinitely as long as the cancer is considered active, or until the patient is declared cancer-free. This reflects the persistently high risk of VTE recurrence in patients with active malignancy.
The duration of anticoagulation has also seen a fundamental shift in its conceptual approach, hasn't it? Based on more recent trials and observations, what's the biggest change in thinking here, especially regarding terms like provoked versus unprovoked?
Yes, this is a really important evolution. The European Society of Cardiology's 2019 Pulmonary Embolism Guidelines, which are referenced in tables 279-5 and 279-6, are particularly instructive here. Critically, terminology such as provoked versus unprovoked, PE or DVT, is no longer really supported by these guidelines as the primary driver for duration decisions.
Why not? That seemed like a clear distinction.
Because the evidence showed that many types of VTE previously classified as provoked, for example, by minor or transient risk factors like estrogen therapy or a long flight, actually lead to as great a risk of recurrence after anticoagulation is discontinued as those VTE events considered unprovoked, meaning no identifiable trigger.
Ah, so the risk was similar even if there was a trigger.
In many cases, yes. This old categorization was often misleading for making decisions about how long to treat. It could lead to stopping anticoagulation prematurely in some patients who actually remained at significant risk.
That's a really significant shift. So how do the new guidelines recommend approaching the duration of anticoagulation for a patient with, say, a first episode of PE?
The newer guidelines recommend that extended oral anticoagulation, often of indefinite duration, should be considered for nearly all patients with a first episode of PE, unless the provoking factor was major transient risk factor, like major surgery. This includes patients with no identifiable risk factor, what used to be called unprovoked, those with a persistent risk factor, like ongoing cancer or antiphospholipid syndrome, or even those with a minor transient or reversible risk factor, like that long-haul flight or estrogen use.
Wow. So indefinite for most people after a first PE, unless it was caused by major surgery or trauma.
That's the general thrust, yes. This shift in thinking challenges those previous assumptions based on the provoked-unprovoked label and significantly simplifies the decision-making for long-term management. It moves towards a more individualized, risk-based approach, focusing on the actual risk of recurrence rather than just the nature of the initial trigger. It's a big change towards longer treatment for many.
Can you give us some concrete examples of recurrence risk levels after stopping anticoagulation according to these newer concepts?
Certainly. Table 279.6 gives some estimates. A low risk of recurrence, maybe less than 3% per year, is typically seen after stopping anticoagulation if the initial VTE was provoked by major surgery or major trauma.
Okay, low risk there.
An intermediate risk, maybe 3–8% per year, is associated with VTE provoked by things like minor surgery, hospitalization with an acute medical illness, pregnancy or estrogen use, a long-haul flight, or conditions like inflammatory bowel disease or autoimmune disease. And interestingly, this intermediate risk category also includes those with no identifiable risk factor, the formerly unprovoked group.
So unprovoked falls into intermediate risk, not necessarily high risk.
Correct, in this framework. And then a high risk of recurrence greater than 8% per year is seen in patients with active cancer or antiphospholipid syndrome. These risk estimates really help guide that individualized decision about whether extended or indefinite anticoagulation is warranted.
Okay, next, let's discuss inferior vena cava, or IVC, filters. These are devices placed in the large vein, returning blood from the lower body to the heart, designed to physically catch clots before they can reach the lungs. What are their principal indications? When are they actually used?
The two main principal indications for inserting an IVC filter are very specific and relatively uncommon. First, active bleeding that absolutely precludes the use of any anticoagulation therapy. The patient is bleeding, can't get blood thinners, but has a clot.
Right, need to prevent PE somehow.
Exactly. The second is documented recurrent venous thrombosis, despite the patient already receiving intensive therapeutic level anticoagulation. So true anticoagulation failure.
Okay. Are there other, maybe less strict indications?
There are some softer indications that are sometimes debated, things like prevention of recurrent PE in patients who have evidence of right heart failure, but are not candidates for more aggressive therapy like fibrinolysis. Or sometimes prophylaxis for extremely high-risk patients undergoing certain procedures, though that's controversial.
What are the limitations or downsides of these filters? They sound potentially beneficial, but are there risks?
They do have limitations and potential downsides. The filter itself might fail by permitting the passage of small to medium-sized clots, sometimes via collateral veins that can develop around the filter over time. And paradoxically, by providing a foreign body surface within the vein, filters can actually increase the long-term risk of DVT formation in the legs, even though they usually succeed in preventing those clots from reaching the lungs as PE.
So they stop PE, but might cause more DVT.
That's the trade-off, yes, which is why current practice often favors retrievable filters rather than permanent ones whenever possible. Retrievable filters can potentially be removed months or even years after insertion, as long as significant thrombus hasn't formed and become trapped within the filter itself. This offers a potentially safer temporary solution when needed.
When it comes to the management of massive PE, those patients who are hypotensive, often in cardiogenic shock, heroic measures may be warranted. Let's start with fluid management. It's not as simple as just giving lots of fluids, is it?
No, it's a very delicate balance. For fluid management, the initial step might be to replete volume cautiously, with maybe 500 milliliters of normal saline if they seem volume depleted. However, additional fluid must be infused with extreme caution.
Why? What's the risk of too much fluid?
Excessive fluid administration can actually exacerbate right ventricular wall stress. It can worsen RV ischemia by increasing wall tension, and it can worsen left ventricular compliance and filling by causing further interventricular septal shift toward the left ventricle. So, too much fluid can paradoxically worsen the patient's hemodynamic status. Very careful titration is needed.
Okay. What about medications to support blood pressure and heart function in massive PE, vasopressors and inotropes?
Right. For vasopressors and inotropic agents, norepinephrine is generally considered the first-line vasopressor for PE-related shock. It helps increase right ventricular inotropy, the force of contraction, and importantly, it increases systemic arterial pressure, which helps restore coronary perfusion pressure to the struggling right ventricle.
Okay, norepinephrine first. What about others?
Dobutamine is often considered a first-line inotropic agent because it directly improves RV contractility. However, it can also cause vasodilation and may worsen systemic hypotension if used alone. So it's often used in combination with a vasopressor like norepinephrine. The key is maintaining a very low threshold for initiating these pressor and/or inotropic agents early in suspected massive PE with shock.
And what if these initial measures, fluids, pressors, inotropes, aren't enough? What are the truly heroic measures?
If truly heroic measures are warranted because the patient is deteriorating rapidly despite initial support, then veno-arterial extracorporeal membrane oxygenation, or VA-ECMO, can be considered.
ECMO.
This strategy should generally only be employed as a bridge to definitive treatment like thrombolysis or surgical embolectomy. ECMO provides temporary cardiac and respiratory support, buying time while a more permanent solution to remove or dissolve the clot is pursued.
Fibrinolysis, also known as thrombolysis using clot-busting drugs, is a powerful intervention aimed at dissolving existing clots. What are its main benefits in acute PE, especially massive PE?
Successful fibrinolytic therapy can rapidly reverse right heart failure in massive PE, and it may result in a lower rate of death and recurrent PE compared to anticoagulation alone in this high-risk group.
How does it achieve that?
It works through several mechanisms. It directly dissolves much of the anatomically obstructing pulmonary arterial thrombus. It also prevents the continued release of serotonin and other neurohumoral factors from activated platelets trapped in the clot, which helps reduce pulmonary vasoconstriction. And it may also lyse much of the source thrombus back in the pelvic or deep leg veins, thereby decreasing the likelihood of recurrent PE from those sites.
What's the standard FDA-approved regimen for systemic fibrinolysis for PE?
The main U.S. Food and Drug Administration, FDA-approved systemically administered fibrinolytic regimen for PE, is 100 milligrams of recombinant tissue plasminogen activator, or TPA, alteplase, prescribed as a continuous peripheral intravenous infusion over 2 hours.
Okay, 100 milligrams over 2 hours. Doesn't matter when it's given.
Generally, the sooner thrombolysis is administered after the onset of massive PE, the more effective it is likely to be. However, it can still potentially be beneficial and used up to 13 days after the PE has occurred, though efficacy likely diminishes over time.
Are there other dosing strategies used? And what are the major risks we worry about with thrombolysis?
Yes, a popular off-label dosing regimen, particularly used in some centers for submassive PE or as an alternative, is 50 milligrams of TPA administered over 2 hours. Some studies suggest this lower dose may be associated with fewer bleeding complications while potentially maintaining efficacy, although data are mixed.
And the risks. Bleeding must be the main one.
Bleeding is the major risk, absolutely. There are significant contraindications to fibrinolysis, including any history of intracranial hemorrhage, recent major surgery or trauma, active internal bleeding, etc. The overall major bleeding rate with systemic fibrinolysis is around 10%, and critically, this includes a 2–3% risk of intracranial hemorrhage, which can be catastrophic. So careful patient screening for contraindications is absolutely crucial to minimize this bleeding risk.
Now, for patients with submassive PE, those who have preserved systolic blood pressure, but evidence of moderate or severe right ventricular dysfunction, the use of fibrinolysis remains quite controversial, doesn't it? What's the current thinking there?
Yes, this is a major area of ongoing debate and research. A 2019 American Heart Association scientific statement suggested considering advanced therapy, which could be thrombolysis or catheter-based intervention, or even embolectomy in these intermediate-risk patients if they show specific signs.
What kinds of signs?
Signs like a lack of improvement or clinical deterioration despite standard anticoagulation alone, or evidence of severe physical distress, maybe imaging showing a large clot burden or a clot in transit in the right heart, severe or persistent RV strain on echo or biomarkers, signs of low cardiac output. And importantly, the patient should have a low perceived bleeding risk and a reasonably good underlying life expectancy.
So it's really an individualized decision.
Highly individualized. This nuanced approach highlights the ongoing debate. The potential benefits of aggressive clot dissolution in preventing deterioration must be weighed very carefully against the significant bleeding risks in these intermediate-risk patients. It often involves multidisciplinary discussion, maybe with a PE response team.
Peers.
Pharmacomechanical catheter-directed therapy offers an alternative to giving the clot buster systemically. What does this approach entail? How does it work? Right, this approach usually combines physical fragmentation or pulverization of the thrombus using a catheter with simultaneous catheter-directed low-dose thrombolysis delivered right into the clot.
What kind of mechanical techniques are used?
There are various mechanical techniques. Things like catheter maceration, where the catheter tip is used to break up the clot, intentional fragmentation and embolization of clot more distally into smaller vessels, suction thrombectomy, trying to suck the clot out, rheolytic hydrolysis, which uses a high-velocity saline jet to break up the clot, and also low-energy ultrasound-facilitated thrombolysis, where ultrasound waves emitted from the catheter help the thrombolytic drug penetrate deeper into the clot.
So a key advantage here is using a much lower dose of the clot-busting drug compared to systemic therapy.
Exactly, that's a major goal. A key advantage of pharmacomechanical catheter-directed therapy is that the total dose of alteplase, TPA, can be markedly reduced, typically to a range of maybe 20-25 milligram total, sometimes even less, instead of that 100 milligram systemic dose. In 2014, the FDA approved one specific device using ultrasound-facilitated catheter-directed thrombolysis for acute massive and submassive PE. Studies using this approach, often with a total PPA dose around 24 milligrams administered over 12 hours or so, showed benefits like decreased right ventricular dilation, reduced pulmonary hypertension, and a decreased anatomic thrombus burden on imaging, while appearing to minimize the risk of intracranial hemorrhage compared to systemic lysis. Lower doses and shorter infusion durations are continually being studied, always aiming for that balance of efficacy and safety.
Pulmonary embolectomy, the actual surgical removal of the clot, has seen a bit of a resurgence in interest lately. What led to this renaissance, as the source calls it?
Primarily, it was the significant risk of major hemorrhage, especially intracranial hemorrhage, associated with systemically administered fibrinolysis that prompted a renewed interest in surgical embolectomy. This operation had almost become extinct for a while. Improvements in more rapid referral of appropriate patients before the onset of irreversible multisystem organ failure, coupled with enhanced surgical techniques and postoperative care, have resulted in significantly improved survival rates for patients undergoing this major operation. It offers a direct and immediate removal of the clot burden, which can be life-saving for very unstable patients or those with contraindications to lysis.
Looking at the long-term picture now, chronic thromboembolic pulmonary hypertension, or CTEPH, develops in a small but significant percentage of acute PE survivors. What's the recommended follow-up for patients who initially had pulmonary hypertension with their PE?
Right. CTEPH develops in roughly 2 to 4% of acute PE patients within the first couple of years. Therefore, PE patients who initially present with pulmonary hypertension, usually diagnosed or suspected based on Doppler echocardiography findings during the acute phase, should be followed up systematically, typically around 6 weeks after discharge, and if necessary, again at 6 months with repeat echocardiograms.
And the goal is to see if the pulmonary hypertension has resolved.
Exactly. The goal is to determine whether the pulmonary hypertension has resolved as the acute clot resolved, or if it persists, suggesting the development of chronic organized thrombus causing CTEPH.
And if it persists, what's the definitive treatment for CTEPH?
If the pulmonary hypertension persists and CTEPH is confirmed, often with further imaging like VQ scans and right heart catheterization, the patient should then be considered for pulmonary thromboendarterectomy or PTE surgery.
PTE surgery, that sounds major.
It is a major complex surgical procedure. But when successful, it can markedly reduce and sometimes even completely cure the pulmonary hypertension by surgically removing the chronic organized clot material lining the pulmonary arteries.
How is it done?
The operation requires a median sternotomy, opening the chest cardiopulmonary bypass, deep hypothermia, cooling the body significantly, and even periods of hypothermic circulatory arrest, where blood flow is temporarily stopped to allow the surgeon a bloodless field to meticulously dissect the chronic clot material out of the pulmonary arteries.
Wow, what's the risk?
The operative mortality rate at experienced high-volume centers is now approximately 5%, which is significantly better than it used to be. Still substantial. For patients who are deemed inoperable due to the location of the clot or comorbidities, management typically involves medical therapy with pulmonary vasodilator drugs and sometimes balloon pulmonary angioplasty of specific webs or stenosis in the pulmonary arteries.
Okay, shifting gears slightly but importantly, beyond all the clinical procedures and medications, there's a vital human element to consider in the journey of a VTE patient: emotional support. What's the patient experience often like after a diagnosis like PE or DVT?
Patients with VTE often feel profoundly overwhelmed when they first learn they are suffering from PE or DVT. For many, as you can imagine, it's their first encounter with a serious, potentially life-threatening cardiovascular illness.
Yeah.
They often harbor fears about adapting to new limitations, maybe imposed by long-term anticoagulation. They worry about the health of their families, especially if there might be genetic implications. And even those who are eventually advised to discontinue anticoagulation may feel especially vulnerable about the potential for suffering a recurrent VTE. There's often significant anxiety. This really highlights the psychological burden that comes with the condition.
Thankfully, support systems exist to help patients navigate these emotional and psychological needs. What examples does our source provide?
Our sources highlight a long-standing physician-nurse-facilitated PE support group at Brigham and Women's Hospital in Boston, which has apparently met monthly for over 30 years to address exactly these kinds of concerns.
30 years. That's
It
amazing.
is. And additionally, the nonprofit North American Thrombosis Forum, whose website is natfonline.org, has initiated monthly online support groups that now garner worldwide participation, making support much more accessible globally, regardless of location.
That's great.
If we connect this to the bigger picture, it just underscores the critical role of comprehensive care that extends beyond just the medical treatment. It needs to include vital emotional and psychological support for the long-term well-being and adaptation of these patients and their families. It's truly an essential component of their recovery journey.
Finally, let's explore how we can prevent these life-threatening conditions in the first place, because prevention is truly paramount, isn't it? Especially given VTE's difficulty in detection sometimes and its profound medical and economic burden.
Absolutely. Prevention or prophylaxis is key. In hospital prophylaxis, preventative treatment given during a hospital stay is a common and essential strategy, particularly for moderate to high-risk patients.
What are the most common forms?
The most frequent forms involve pharmacological agents like low-dose unfractionated heparin, UFH, given subcutaneously, or low molecular weight heparin, LMWH, also given subcutaneously. To ensure adherence among healthcare providers, which can sometimes be a challenge, computerized reminder systems or standardized protocols have been shown to significantly improve compliance rates. Mechanical methods like intermittent pneumatic compression devices are also important, especially when drugs are contraindicated.
Our sources detail specific prophylaxis strategies outlined in Table 279-7 for various patient populations, quite a detailed list. Let's touch on some key groups. What about patients undergoing high-risk non-orthopedic surgery?
For high-risk general or abdominal pelvic non-orthopedic surgery, options typically include pharmacological prophylaxis with UFH, UG 5,000 units subcutaneously 2 or 3 times daily, or LMWH like enoxaparin, for example, 40 milligrams daily, or dalteparin for 5,000 units daily. These aim to prevent clots during that vulnerable perioperative period.
And for medical oncology patients or those undergoing specific cancer surgery, cancer is a big risk factor.
Yes, cancer is a major risk factor. In medical oncology patients, particularly those receiving certain chemotherapies or who have other risk factors, prophylaxis might involve LMWH, enoxaparin or dalteparin, or increasingly one of the oral factor Zads inhibitors like rivaroxaban or apixaban based on recent trials. For patients undergoing major cancer surgery, including gynecologic cancer surgery, LMWH like enoxaparin, 40 milligrams daily, is common, and often extended prophylaxis for up to 1 month post-discharge is considered due to the prolonged VTE risk.
Major orthopedic surgery, hip and knee replacements has a particularly high risk and a wide array of options listed. What are some of the key choices there?
Yes, major orthopedic surgery carries a very high VTE risk, so prophylaxis is standard. The options are broad, reflecting lots of research in this area. They include warfarin, targeting an INR of 2.0, 3.0, though less common now, LMWH like enoxaparin, often 30 milligrams twice daily or 40 milligrams daily, or dalteparin, fondaparin X, 2.5 milligrams daily.
Okay.
Also, the NOACs are widely used here. Rivaroxaban, 10 milligrams daily, typically started 6-10 hours post-op. Dabigatran started at a lower dose first day, then 220 milligrams daily, or apixaban, 2.5 milligrams twice daily, usually started 12-24 hours post-op. Even aspirin is listed as an option in some guidelines, particularly after an initial period of stronger anticoagulation. The duration is often extended for several weeks post-surgery.
And for general medically ill patients admitted to the hospital, especially if they are immobilized or have other risk factors, what's recommended?
For medically ill patients admitted to the hospital, think pneumonia, heart failure, etc., especially if they are immobilized, have a history of prior VTE, an indwelling central venous catheter, active cancer, or other risk factors. Prophylaxis is generally recommended. But importantly, this is usually without certain high-risk features, like an active gastroduodenal ulcer, major bleeding within the past 3 months, or a very low platelet count, for example, 50,000. If they meet criteria, prophylaxis typically includes UFH, 5,000 units 2 or 3 times daily, LMWH like enoxaparin 40 milligrams daily or dalteparin 5,000 units daily, or fondaparin X 2.5 milligrams daily.
Are there specific options recommended for medically ill patients right around the time of discharge, or what if anticoagulation is contraindicated altogether?
Yes, for extending prophylaxis after discharge in certain high-risk medically ill patients, rivaroxaban has been studied and is an option based on specific trial criteria. Finally, in situations where pharmacological anticoagulation is absolutely contraindicated due to bleeding risk, then mechanical prophylaxis with intermittent pneumatic compression devices, IPCs applied to the legs, is the recommended approach. However, the effectiveness of simple graduated compression stockings alone for VTE prevention in medical patients remains uncertain based on current evidence.
So what's the key takeaway for you regarding VTE prevention in a hospital setting, or maybe for your loved ones if they're hospitalized?
It really underscores the existence of diverse, evidence-based strategies and the need for highly personalized approaches to VTE prevention. It means that VTE risk should be assessed for virtually every hospitalized patient, and prophylaxis should be implemented proactively across a wide range of clinical scenarios when indicated. Clinicians make careful choices based on a patient's specific risks, the type of surgery or illness, mobility level, bleeding risk, etc., and their medical history. Prevention is truly a cornerstone of patient safety in the hospital and managing the burden of these potentially devastating conditions.
Well, we have taken a truly comprehensive deep dive today. We've covered deep venous thrombosis and pulmonary thromboembolism, connecting it back to those crucial initial notes on hypertension and renal issues from the start of our source.
We covered a lot of ground.
We really did. From the, silent epidemiology and the incredibly complex pathophysiology through the nuanced classification systems, the sophisticated diagnostic methods, and that intricate world of treatment and prevention. We've navigated a vast landscape of knowledge, really aiming to master the insights from Chapter 279.
And we've seen how these conditions truly are the great masquerader, how their impact is, quite alarmingly, increasing in some populations, like younger adults in the U.S. for PE mortality. And we've touched on the constant evolution of diagnostic tools and therapeutic strategies.
Yeah.
The whole journey, really, from initial suspicion through diagnosis and on to long-term management, requires such a sophisticated understanding of these interwoven biological processes and some very nuanced clinical decision-making. We hope this deep dive has really empowered you with the knowledge to truly grasp this information, like the elite professional strives to.
Absolutely. So, as we wrap up this deep dive, here's a provocative thought for you to consider. Given those rising mortality rates in some regions, the ongoing challenges of timely and accurate diagnosis, and all the complexities of long-term care and patient support we discussed, what do you think is the single most critical innovation or perhaps policy change needed to dramatically improve outcomes for VTE patients worldwide in the next decade?
That's a great question to ponder.
Something to mull over until our next deep dive.